Hi everyone, myself Dr. Prasad, Department of General Medicine. Today in this video I am going to discuss about an important drug, that is the hydrocortisone. Before really going into the hydrocortisone, a quick recap about the adrenal gland and its secretions. So this is an adrenal gland, and the central portion of the adrenal gland is the adrenal medulla, which is shown in the yellow color. Surrounding the adrenal medulla, there is an adrenal cortex, which is shown in the green color. The green color zone which is surrounding the adrenal medulla is the adrenal cortex. This adrenal cortex is further divided into three different portions. So, the outermost portion of the adrenal cortex is the zona glomerulosa. The middle portion of the adrenal cortex is the zona fasciculata. The innermost portion of the adrenal cortex is the zona reticularis. Coming to the secretions of the adrenal gland, the two important catecholamines which are secreted from the adrenal medulla are the epinephrine and the norepinephrine. Coming to the secretions of the adrenal cortex, from the zona glomerulosa portion of the adrenal cortex, the mineralocorticoids are secreted. The glucocorticoids are secreted by the zona fasciculata of the adrenal cortex, and the androgens are secreted from the zona reticularis of the adrenal cortex. Coming to the mineralocorticoids, which are secreted from the zona glomerulosa of the adrenal cortex. The example of the mineralocorticoids is the aldosterone. The main function of the mineralocorticoids is to maintain the blood pressure throughout the day and maintain the electrolyte balance throughout the day. By acting on the principal cells and the intercalated cells, this aldosterone reabsorbs the sodium and water from the urine into the blood and also secrete the potassium and H+ from the blood into the urine. In this way, they maintain the blood pressure and the electrolyte balance throughout the day. Coming to the glucocorticoids, which are secreted from the zona fasciculata of the adrenal cortex. The hydrocortisone is an example of the glucocorticoids. Coming to the properties, the main effect of the glucocorticoids on the metabolism is the catabolism, because the glucocorticoids are the catabolic hormones. They break everything in the body. For example, they break the carbohydrates. This results in increase in the blood glucose, so usually avoid in diabetes patients. And they break the proteins, cause the proteolysis. This results in muscle damage, that cause the muscle weakness. So usually glucocorticoids cause proximal type of myopathy. They also break the fats, that is, they cause the lipolysis and results in the increased free fatty acid production. So these increased free fatty acids deposited in abnormal areas of the body, like they deposit on the face, causing round face and result in a buffalo hump, and also deposited in the supraclavicular area, causing supraclavicular filling, and they also deposited in the central abdomen, causing central obesity. This is called the centripetal obesity. This gives a characteristic appearance of the patient, that is the lemon on stick appearance. So what is the lemon on stick appearance? This is the lemon on stick appearance. Here the patient limbs are very thin, but the abdomen and the face are very large. This gives the lemon on stick appearance. And the glucocorticoids also breaks the calcium from the bone, because the glucocorticoids have osteoclastic activity. This results in the osteoporosis. Coming to the second property of the glucocorticoids, the anti-inflammatory property. Because the glucocorticoids have anti-inflammatory property, we are using these glucocorticoids in the type 1 hypersensitivity reaction, that is in anaphylaxis and acute exacerbation of the bronchial asthma. So in these conditions, the glucocorticoids are the first line drugs. And coming to the third property, that is a powerful immunosuppressive drug. The glucocorticoids are the powerful immunosuppressive agents. Where we usually use this immunosuppressive property, that is in autoimmune diseases like SL. In autoimmune diseases, our own immune system overacts and causes the damage. So in such condition, we have to suppress our own immune system. For that purpose, we usually use glucocorticoids. And the conditions like SLE, we usually use glucocorticoids. And during transplantation, that is just a few days before the transplantation, to prevent the graft rejection and to prevent the antigen antibody reactions, we have to immunosuppress the recipient. So to immunosuppress the recipient, we give glucocorticoids to the recipient, so that we immunosuppress the recipient, thereby we prevent the graft rejection. And these glucocorticoids are also having anti-cancer property, so that we are using in Hodgkin's lymphoma, non-Hodgkin's lymphoma and multiple myeloma. Coming to the drugs, the glucocorticoid drugs are further classified into short-acting, intermediate-acting and the long-acting. The short-acting glucocorticoid drugs are the cortisone and the hydrocortisone. The intermediate-acting glucocorticoids are prednisolone and the triamcinolone. Long-acting glucocorticoids are the betamethasone, dexamethasone and the paramethasone. Mineralocorticoid drugs are the aldosterone, fludrocortisone and the DOCA, that is the deoxycorticosterone acetate. So there are few special points regarding these drugs. These are the glucocorticoid drug, which is having maximum mineralocorticoid activity. This is the hydrocortisone. And the most potent glucocorticoid drug is the betamethasone. The glucocorticoid which is having maximum glucocorticoid activity is the dexamethasone. Like that, the aldosterone is the mineralocorticoid which is having maximum mineralocorticoid activity. The fludrocortisone is the mineralocorticoid drug which is having maximum glucocorticoid activity. So fludrocortisone is a mineralocorticoid having maximum glucocorticoid activity. Hydrocortisone is a glucocorticoid which is having maximum mineralocorticoid activity. Coming to the hypothalamo-pituitary adrenal axis, that is the HPA axis, hypothalamic pituitary adrenal axis. This is a very important axis. This maintains the level of steroids in the body. It maintains the steroid levels in the body. So let's see how this HPA axis maintains the levels of glucocorticoids and mineralocorticoids in the body. Let's take, if the glucocorticoid and the mineralocorticoid levels are low, that is less than normal, then hypothalamus starts producing corticotropic releasing hormone. This corticotropic releasing hormone stimulates this pituitary, and this pituitary starts secreting adrenocorticotropic hormone. Now this adrenocorticotropic hormone stimulates the adrenal cortex, then the adrenal cortex in turn produce glucocorticoids and mineralocorticoids. In this way, the reduced glucocorticoid and mineralocorticoids will replenished by the hypothalamus. In this way, when the glucocorticoid and mineralocorticoid levels are low, our own HPA axis start producing the glucocorticoids and mineralocorticoids, and the levels become normalized. Let's say if the glucocorticoid and mineralocorticoid levels are very high. When the levels are very high, these high levels of glucocorticoids and mineralocorticoids gives negative feedback to the hypothalamus and our pituitary gland. By responding to the negative feedback coming from the high levels of glucocorticoids and mineralocorticoids, this hypothalamus stop secreting corticotropic releasing hormone. So when there is no CRH, there is no stimulus to the pituitary gland. When there is no pituitary stimulus, there is no ACTH. When there is no ACTH, no stimulus to the adrenal medulla. When there is no stimulus to the adrenal medulla, there is no production of glucocorticoids and mineralocorticoids. So when the levels are very high, our adrenal gland stop producing glucocorticoids and mineralocorticoids. In this way, our own HPA axis, the entire HPA axis maintains the level of glucocorticoids and mineralocorticoid levels in the body. After knowing the normal HPA axis and its function, let us take one scenario. That is, there is a patient who is taking glucocorticoids from outside, either by IV route or by oral route. So because the patient is taking glucocorticoids, his blood glucocorticoid levels are high. So when there is glucocorticoid levels are high, it gives negative feedback to the hypothalamus. We all know this. So by responding to the negative feedback coming from the high levels of glucocorticoids, this hypothalamus stop secreting corticotropic releasing hormone. So when there is no corticotropic releasing hormone, there is no ACTH coming from the pituitary. When there is no ACTH, there is no stimulus to the adrenal cortex. When there is no stimulus to the adrenal cortex, there is no production of glucocorticoids. Okay, so if you observe very carefully, what is the reason here for the stoppage of production of glucocorticoids? And if you go retrogradely, the reason is this: because the patient is taking the glucocorticoid from the outside, his blood glucocorticoid levels are very high. So these high levels of glucocorticoids gives negative feedback to the hypothalamus. So by responding to the negative feedback, this hypothalamus stops secreting CRH. So when there is no CRH, there is no ACTH. There is no ACTH, there is no stimulus to the adrenal cortex. When there is no adrenal cortex, there is no production of glucocorticoids. So in this way, the glucocorticoid production is stopped when the patient is taking the glucocorticoids from the outside. So if that particular patient is continue taking the glucocorticoids for a period of greater than 2 weeks, his adrenal glands, his own adrenal glands, forget to produce glucocorticoids. Okay, if this patient is continue to use glucocorticoids for a period of greater than 2 weeks, his adrenal glands forget to produce glucocorticoids. This is called as HPA axis suppression. Okay, so even if the patient stop taking the glucocorticoids after 2 weeks, there is no production of the glucocorticoids from the adrenal gland because of this HPA axis suppression. So after 2 weeks, if the patient stop taking the glucocorticoids suddenly, the patient may die because of lack of glucocorticoid production from his own adrenal gland. Okay, this is the reason one should not prescribe the steroids unnecessarily. Okay, why? Now you know the reason, that is HPA axis suppression. As a doctor, if you want to prescribe some steroids to your patient, then try to prescribe for a minimal possible period. Okay, if you want to prescribe steroids to your patient for a period of greater than 2 weeks, then plan alternate day therapy, that is day by day therapy. Or if you want to prescribe steroid daily for a period of greater than 2 weeks, then do not stop steroids suddenly after 2 weeks. Why? Because if we suddenly stop the steroids, his HPA axis is already suppressed, then patient may die because of lack of glucocorticoids. So in that condition, we have to taper the dose of the steroids and reduce the dose of the steroids. So let's see, if the patient is on 20 mg of steroid for a period of greater than 2 weeks, then reduce the dose to 10 mg and continue it for another 7 days, and again reduce the dose to 5 mg and continue it for 7 days, and then to 1 mg, continue it for 7 days. In this way, we have to stop the drug gradually. Instead of stopping the drug suddenly, we have to taper the dose gradually and then stop the drug. In this way, we can prevent the HPA axis suppression. So we have to prescribe the steroids according to these 3 points. But practically, even though we are planning to prescribe the steroids for a period of 5 days, and we are not going to stop the steroid immediately after 5 days, in this particular condition also we are going to taper the dose and stop the drug gradually. Coming to the proper drug, that is hydrocortisone. This is the hydrocortisone which is available in 100 mg vial. So we all know that the hydrocortisone is the short acting glucocorticoid. This is a short acting glucocorticoid, and the hydrocortisone is a glucocorticoid which is having the maximum intracorticoid activity. Coming to the uses of the hydrocortisone has a anti-inflammatory property. Okay, this anti-inflammatory property of the hydrocortisone is very much beneficial in medical emergencies like anaphylactic shock, that is a type 1 hypersensitivity reaction. In the type 1 hypersensitivity reaction, the 2 main important drugs are the adrenaline and the hydrocortisone. And another medical emergency is status asthmaticus, and also during acute exacerbation of the COPD. This hydrocortisone reduces the edema that is present around the area of ischemia and the edema present around the intracranial space occupying lesion. Let's see, this is the, consider this is the brain, and the black one which is present at the center is the intracranial space occupying lesion, whether it may be a tuberculoma, whether it is a tumor, or whether it is a brain abscess. This is the intracranial space occupying lesion. Surrounding the intracranial space occupying lesion, there is a yellow color circle is there. This yellow color circle is a perilesional edema that is present immediately around the intracranial space occupying lesion. This perilesional edema produce pressure symptoms on the surrounding neural structures. This edema produce pressure symptoms. Because of this, patient develop the features of raised ICP, and patient may develop seizures. So in such situation, the hydrocortisone reduces the edema which is present around the intracranial space occupying lesions, so that the pressure over the surrounding neural structures are resolved so that the patient revert back from the features of the ICP, and the seizures also will subside eventually. And everybody knows that during suprachiasmal poisoning, patient develop in early stages patient develop angioneurotic edema of the face and the laryngeal edema. So in all the patients whoever undergone suprachiasmal poisoning, we have to give hydrocortisone because it prevents the development of the laryngeal edema. So we have to give the hydrocortisone before the development of the laryngeal edema. Once the laryngeal edema is developed, patient airway become narrow and patient may enter into respiratory distress. In that condition, in that laryngeal edema condition, intubation is also very difficult. In that particular case, we may lose the patient. So in all the cases of suprachiasmal poisoning, before the development of laryngeal edema, as early as possible we have to give hydrocortisone. Next, coming to as a replacement drug. So in acute Addisonian crisis, what is Addisonian crisis? The Addisonian crisis means the adrenocortical insufficiency. So in that particular condition, we use the hydrocortisone as a replacement drug. And hydrocortisone is a immunosuppressive agent because it is a glucocorticoid. It has a immunosuppressive capacity. So this immunosuppressive property of the hydrocortisone is used in autoimmune diseases and during transplantation. And this hydrocortisone also have some anti-cancer property, so we use it in Hodgkin's lymphoma, non-Hodgkin's lymphoma, and multiple myeloma. Coming to the adverse effects and the contraindications of the steroids. So number one is glaucoma. So when we use the steroids as eye drops for a long period, the patient develop the steroid induced glaucoma. We all know that hydrocortisone, that the steroids are the catabolic hormones, they break everything. So they also break the proteins because of proteolysis. Because of the proteolysis, patient muscles become atrophy and patient present with a muscle weakness, that is the myopathy. Predominantly we observed proximal type of myopathy in such patients. And third one is peptic ulcers. So the over usage of the steroids will cause peptic ulcers. Number four is a cataract. So when we use the steroids systemically, patient will develop steroid induced cataract. So if we use systemically, patient developed cataract. If we use as eye drop, patient develop glaucoma. We also know that it also, this hydrocortisone is also have osteoclastic activity, so it breaks the calcium from the bone, so it causes the osteoporosis, and it causes the Cushing's syndrome, and it also causes osteonecrosis, that is the avascular necrosis of the bone. These steroids are contraindicated in tuberculosis, particularly in the intestinal tuberculosis. If we give in that particular intestinal tuberculosis condition, this results in silent perforation of the intestine. And this hydrocortisone, this steroid, because it is a strong immunosuppressive agent, it impairs the healing process, and we usually avoid the steroids in congestive heart failure because this hydrocortisone is a strong, this hydrocortisone is also have a strong mineralocorticoid activity, so it reabsorbs the sodium and water, so the preload increases again. So when the preload increases, the heart is already failure. In that condition, if we increase the preload, the symptoms of the congestive heart failure become worsen. So we usually avoid in CHF patient because it breaks down the protein, carbohydrates, it increases the blood glucose levels, so usually avoid in diabetes mellitus. And the most dangerous side effect of the steroids is the suppression of the HPA axis. So this is the most dangerous side effect. The patient may die because of the HPA axis suppression. Finally, please subscribe my channel, and if you really like this video, please click the like button and share my video and give your valuable comment. Thank you.